Good afternoon, everyone, and welcome to the third and final day of the Women's Health Summit. Thank you to the 92nd Street Y for organizing this amazing event, and to the Katz Institute of Women's Health and Nancy and Larry Roth for their continued support in sharing knowledge and resources to help women take charge of their own health and wellness. I'm Dr. Elaine Schaefer, Associate Medical Director of the Medicine Service Line for the Eastern Region and Assistant Professor of Family Medicine at the Zucker School of Medicine at Hofstra Northwell. I am excited to welcome you to today's Women's Health Summit sessions. When we think of women's health, obstetric and gynecological services often come to mind. And for many women, their OB or GYN can be the main connection to medical care. We understand the importance of that relationship and of the annual Well Woman visit. Today, we'll be hosting an open forum on all the topics you should be bringing up to your doctor, even if they might be a bit embarrassing. Women shouldn't have to suffer through leaky bladders or sexual discomfort. We have experts who can help get you the care you deserve. We'll also dive into breast health. It's normal to experience changes in your breast during your lifetime, most of which are not cause for alarm. Our experts will discuss breast changes, what's normal and what's not, and share tips on how to stay proactive. I'm excited to introduce the first panel for today, What's Going On Down There? Please join me in welcoming our experts.
Good afternoon. I'm Dr. Jill Rabin, head of Urogynecology at Northwell Health. Welcome to Let's Talk About What's Going On Down There. Our expert panel will be discussing all those topics that everyone wants to know about, but is often too embarrassed to mention during healthcare conversations. From concerns about abdominal discomfort and colorectal cancer, to incontinence and other urinary difficulties, and from sexual health for women to the anxiety associated with going to the doctor. My colleagues and I will provide you with timely and practical information that could change your life. With me today are gastroenterologist Dr. Bethany DeVito, urologist Dr. Farzeen Firoozi, and psychologist Dr. Jennifer McKelvey, who are all Northwell Health's Katz Institute for Women's Health specialist. Let's get started. Dr. Firoozi, our urologist. What is overactive bladder?
Okay, thanks so much, Dr. Rabin, for including me in this wonderful panel. So overactive bladder is it's a diagnosis, but it's really a constellation of symptoms. They include symptoms such as urinary frequency, so going to the bathroom very frequently during the daytime, urinary urgency, which is the sudden compelling desire to use the bathroom and having difficulty staving off that urge to get to the bathroom, nocturia, which is getting up in the middle of the night to use the bathroom. And in some patients, there can be a type of incontinence, which we can talk about a little bit later, called urge incontinence, which is the inability to actually get to the bathroom in time and then having an incontinent event. So when we talk about overactive bladder, it could be any one of those four potential symptoms or just one of those symptoms.
And if a patient has one or all of the symptoms associated with overactive bladder, what are the treatment options specifically for overactive bladder?
So when we look at and when we talk to our patients about overactive bladder, we think of them as sort of lines of defense. There are first, second, and third line defenses or treatments that we offer our patients. First line treatment options include sort of non-medicinal, non-interventional options such as fluid modification, so altering what the patient drinks to try to reduce some of those OAB symptoms. So things like reduction in caffeine, hot and spicy foods, specific foods that can irritate the bladder, and then also just overall fluid volume intake. We'll assess that with a voiding diary and see specifically how much fluid the patient is drinking and how much urine they're making, and try to alter that to try to reduce some of those overactive bladder symptoms. There's also bladder retraining techniques, which include things like Kegel exercises to try to build up pelvic strength and also dampen some of those urgency-associated urinary symptoms. So those are some first-line therapies that we always start with when we counsel our patients to treat their overactive bladder. The next line or second line therapies include medicines that we can offer our patients. There's two main categories of medicines that we use. One is called anticholinergic, and there's about 11 or 12 different agents that are on the market. One, for example, is oxybutynin, which is probably one that maybe most have heard of, which is essentially, think of it as an antispasm medication. It helps control that bladder overactivity that causes a lot of those symptoms. The other category of medicines are called beta-3 agonists, which is, again, another pathway to calm that overactive bladder, overactive muscle of the bladder that causes a lot of those overactive symptoms. There's two agents within that field that are currently available on the market. And then when we talk about third line therapies, those are really more advanced interventional options. And that would include two main categories. One is botulinum toxin, or Botox, as it's popularly known as. Botox is used most commonly, people are familiar with it for cosmetic use, but we do also use it urologically. I know in gastroenterology field as well, they use it for some indications. The Botox is injected actually into the muscle of the bladder, and just as it does in someone's face when it's injected in the face, it relaxes some of those muscles, specifically in the bladder, and by relaxing them, what's called chemodenervation, relaxes some of that bladder overactivity. The other category falls under the umbrella of what we call neuromodulation, which there are many neuromodulatory options. Effectively, what that therapy does is via specific routes sending electrical impulses to the bladder, the nerves around the bladder, to again calm that bladder overactivity. Within neuromodulation, there's posterior tibial nerve stimulation, which is an office-based treatment option that we offer our patients, which is done on a weekly basis in the office. And then there's more invasive options, which include sacral nerve stimulation, which sort of in the lay way, we would just refer to it as more like a pacemaker for the bladder, which is also a good third line therapy option. Those third line therapies generally are really more for refractory patients. In other words, patients who've tried in earnest some of those simpler first and second line therapies and have still had persistent overactive bladder symptoms, at which point we can offer them some of those more advanced therapies.
That was very comprehensive overview of overactive bladder. I learned something. And I want to ask you our second question for you. What are the main types of incontinence that women suffer with in the United States?
So there are several different types of incontinence that we see as pelvic floor specialists. I'm going to hone in on sort of two of the main types of incontinence that we see. That would be stress urinary incontinence, which is incontinence associated with any type of activity. So that would be things like coughing or sneezing, laughing, exercising, lifting heavy objects, anything that causes an increase in the abdominal pressure. That pressure gets transmitted to the bladder, and that stress on the bladder causes leakage. That's usually caused by two anatomical issues. One is hypermobility of the urethra, and the other is sphincteric deficiency, both of which basically cause the outlet, which is sort of like the opening of the urinary tract, to be incompetent and not function properly. The other type of incontinence that women typically will come and see pelvic floor specialists for is urge incontinence, which I sort of alluded to when we were talking about overactive bladder or OAB. Urge incontinence is, again, that incontinence associated with the sudden urge to use the bathroom and not get there in time. And there's some triggers that women will sometimes report, such as running water or being outside in cold weather or the sound of the key hitting the front door lock. Those types of triggers trigger that urge, and then they're unable to get to the bathroom in time. So those are the two main types of incontinence. And not infrequently, we see patients who have what we call mixed incontinence, meaning they can actually have both components, either equivalent, meaning the urge and stress bothers them the same, or they can actually have a predominance of one versus the other. So we would say Someone who has stress predominant mixed incontinence has primarily stress incontinence that bothers them with a smaller degree of urge, and vice versa for patients who have urge predominant mixed urinary incontinence.
That's very comprehensive. You went through the treatments for overactive bladder, but I would like you to elaborate on a little bit more on the different treatments available specifically for stress incontinence or stress predominant urge incontinence.
Right. So stress incontinence or stress predominant urge incontinence, again, it being essentially a anatomical issue, there really are no medicines available for that, like we talked about for overactive bladder. So it's really a matter of trying to address the anatomical deficiency that we're dealing with that's causing the stress incontinence. So the first thing, just like we talked about treatments for overactive bladder, as physicians, we try to employ the least invasive option first with our patients. So mentioning before, Kegel exercises, so pelvic strengthening exercises can sometimes increase the pelvic strength, and by doing so, improve some of those stress incontinence symptoms in women. And either we can teach patients how to do Kegel exercises in the office, or sometimes more advanced pelvic strengthening techniques by having them see a pelvic floor physical therapist. Another non-interventional option would be the realm of vaginal inserts. So that would be either in the form of anti-incontinence pessaries or anti-incontinence inserts. So that's essentially placing something inside the vagina, like a pessary, which is a rubber ring that can apply support to the area that's lacking strength and stopping the incontinence by using that. There are also different vaginal inserts that are used that are softer, again, placed almost like a tampon, but a little bit more firm version of what would be a tampon, again, by applying pressure to the urethra intravaginally to afford some more continence. So those are some of the non-interventional options. And then in patients who either have tried some of those initial therapies and have failed, or maybe wish to have more definitive success for their stress incontinence, there are surgical options. The two main sort of categories of surgical options would include bulking agents. So that's a procedure where endoscopically, no incisions are made in the body, a small camera is placed into the urethra, and effectively small bubbles of implants are placed alongside the urethra to support the area that's weak. So those are bulking agents. And there are newer ones that are coming out on the market. One that's recently come out in the last year, which has had some more success compared to previous bulking agents that have been used. And the other option is slings. And those are different forms of slings. There are midurethral synthetic slings, which are exactly how they're termed, synthetic, they come in a box, or there are fascial slings. So making a sling or a hammock, if you will, out of the patient's own tissue. So that's essentially a transvaginal procedure where that sling is placed under the urethra to support it, so that when there's coughing or moving or exercising, there isn't incontinence as a result of it because of that support that's placed there.
Very interesting. I like the distinction between the synthetic and the fascial sling. Very, very interesting. So those are a lot of choices. So really, they're quite important for patients to know their diagnosis and get a treatment plan with someone they can talk to. It certainly seems you are a urologist who people can talk to and ask questions and bring questions. So this has been wonderful. I have one final question for you. What is pelvic floor dysfunction and how is it treated?
Yes. So that's actually a quite common issue we see in our office, pelvic floor dysfunction. And it's, simply put, it's effectively two things that are going on wrong with the pelvic floor or the pelvic floor muscles. One is the inability for the female patients to properly relax their pelvic floor in terms of moving their bowels or avoiding urinating, as well as an incoordination of those muscles. So when you have a combination of inability to relax and an incoordination of those muscles, that could actually affect a lot of pelvic floor functions, mainly urinary function and bowel function, and possibly maybe Dr. DeVito can talk a little bit about, the bowel issues associated with pelvic floor dysfunction. But in women with pelvic floor dysfunction, we commonly see voiding issues because the bladder is we look at it as a bystander, something that's affected by those pelvic muscles that aren't working properly.
Well, I want to thank you for being with us today and invite you to stay on, and other questions may come up. That's all I have for you at this point. So we're going to move on to Dr. Bethany DeVito, our gastroenterologist, and ask her some questions, 3 questions specifically. So Dr. DeVito, welcome. Thank you so much for joining us. Thank you for joining us. Wonderful to see you. I have a couple of questions for you. This is also, just as incontinence is extremely important, bowel health is extremely important, and they basically work together, bladder and bowel, and the pelvic organs in terms of uterus and so forth. But I'm going to confine my comments to your specialty right now. I'm going to ask you a few questions, such as, why might women in particular have symptoms of abdominal pain and bloating? What might they mean? When should they worry? And when should women see a doctor for advice?
Yeah, so thank you, Jill, for including me here, by the way. I would say that most women come to see me. Number one complaint is usually abdominal pain and bloating. If I had a cure for bloating, it would be like a wonderful world for women, quite honestly. So bloated stomach is that feeling of fullness in the belly, tightness, pressure. It may or may not be accompanied by visibly distended or swollen belly. Some women actually tell me that they feel pregnant, and then it goes away later on. And the feeling can be a sensation of just feeling mildly uncomfortable to intensely painful. Some people actually end up in the emergency room with this feeling of being really uncomfortable. Usually it goes away after a while, but for some people it is a recurring problem. I would say the most common cause of stomach pain and bloating is due to excess intestinal gas. And this is usually caused by either eating too much or eating too fast, or could be caused by a food intolerance. I always tell my patients who comes in with complaints of bloating, you are what you eat. There's something in your diet that you're not tolerating well, and you have to evaluate your diet. I would ask them about dairy products, how much dairy they have. Lactose intolerance is very, very common, especially in certain ethnic populations and as one gets older. So lactose is sugar found in milk, cheese, yogurt, ice cream. A lot of people have symptoms of lactose intolerance, gas, bloating, and even urgency when you have too much of milk. In some people, it's fructose intolerance. They have too much fruits and vegetables, or people who, let's say, drink too much fruit juices or have dried fruits, or gluten intolerance. People tell me, I think I have celiac disease. And I ask them why. Because when I have bread, I get gassy and bloated. There's not too many celiacs out there. So gluten is a protein found in wheat, rye, barley. And celiacs basically have just make it simple, and so like an allergic reaction to gluten, in that when they have gluten, it damages their small bowel, and with that they get anemia, diarrhea, symptoms of bloating. There's not too many celiacs. There's a lot more people who are gluten intolerant. So I tell people, go on lactose-free diet. Elimination diet is the key. 2 weeks lactose-free. If it's not enough, 2 weeks gluten-free. And if it's not enough to help you, do a food diary. See what makes you feel bloated and gassy. A woman's menstrual cycle is another common cause of temporary bloating. Right before menses, a lot of people complain about being bloated, and my constipated patients, believe it or not, go to the bathroom better. And that has to do with the imbalance between estrogen and progesterone just before the menses. Many women also suffer from a condition called irritable bowel syndrome, or IBS. And other terms used for that, spastic colon, nervous stomach. So women with this condition will complain of chronic abdominal pain, usually pelvic pain, lower abdominal pain, cramping as if they're having their period, bloating, and they have symptoms of either diarrhea or constipation. So many causes for bloating, but I would say probably the number one cause, diet.
Very comprehensive answer, and very reassuring, I might add. So let's take a little bit of a deeper dive into the subject and talk about colon cancer screening. When should a woman start screening for colon cancer?
So colorectal cancer is the third leading cause of cancer deaths in both men and women. So it's very common and it's a very preventable type of cancer. So recently, the American Cancer Society and the U.S. Preventive Services Task Force have lowered the baseline screening age for colon cancer from age 50 to age 45. Reason being is we're finding younger and younger people developing colorectal cancer before they're 50. It's been estimated that more than 10% of new colorectal cancer cases occur in people younger than age 50. So we want to catch them early because it is a very preventable type of cancer.
I understand there are some new guidelines, some even newer guidelines for average risk people.
So the average risk, we used to screen starting at 50, and now we start screening at age 45, unless there is a risk for high risk for colon cancer, meaning that they have a family history of colon cancer or colon polyps. And those we start screening at age 40 or 10 years younger if their affected relative, first degree relative is young. Like for instance, if their mother, father, brother, sister had colon cancer at age 45, we would start them at age 35.
I see. I want to just jump in here with a little bit of an extra question. I know you probably hear this all the time. I certainly do. As a gynecologist, a urogynecologist, when I recommend colon cancer screening for my patients, the first thing I hear is, oh, I really hate the prep. Can you talk a little bit about the prep?
So it's gotten better. People think about the prep as a gallon of nasty tasting a liquid. We actually don't use that unless, of course, it's the cheapest one. So unless, of course, they want the cheapest possible and they don't want to pay for anything more expensive because that's covered by insurance most of the time. But there's other preps out there. There's something called soup prep, which is basically 2 little bottles of 6 ounce fluid. It tastes to me, because I took that prep myself, like salty Robitussin type of liquid. And there's a new one called Clinpic, which is cranberry flavored, and most people will say it's sweet and salty, and it's 5.5 ounce fluid. 2 of them that you don't mix in anything. You drink it straight up and follow with 3 glasses of water. So it's very small volume. The bottom line with the prep really is the day before. Everyone's supposed to be on a clear liquid diet. The most important thing is hydration. Hydrate the day before with clear liquid fluids to prevent feeling sick while they're drinking the prep, because if they're dehydrated because they're not drinking their fluids the day before, and then now they're drinking a laxative that gives them lots of diarrhea to completely clean them out, they feel ill and they don't feel well and they get nauseous and they may vomit the prep. So hydrate well. And then you talk to your doctor about the different preps that are available, because some people have aversion to taste and some people have aversion to volume. So I would ask them individually, what is the issue? Is it the volume or is it the taste? And I will work with them. And there's also an over-the-counter prep called Miralax. Miralax we use for chronic constipation. It's powder. They mix it with any drink that they want, water, Gatorade, juices, vitamin water. So there's different ways of prepping now. So it's really not that bad.
Such good advice, especially the part about hydration. I didn't realize that was so very important. So thank you for emphasizing that. A last question about colon cancer, risks. What are the risk factors for developing colon cancer, and how can a woman reduce this risk?
So the biggest risk is genetics, family history of colorectal cancer or colon polyps, history of inflammatory bowel disease. And those are people with ulcerative colitis or Crohn's colitis, and people with a genetic predisposition to colon cancer like Lynch syndrome or familial adenomatous polyposis. A woman can reduce risk simply by getting screened. Get screened at age 45 or earlier if they have risk factors for colorectal cancer. Getting regular exercise will reduce risk for cancer and most cancers out there. And take control of your weight. Obesity is a risk factor for colorectal cancer. Eating healthy diet rich in fruits and vegetables, avoiding red meats or eat less of it, and processed meats, and avoiding smoking and alcohol.
Of course. So again, just to kind of wrap up this part of the segment. What is your best advice for women to maintain a healthy gut?
So gut health is so important because more than half of our immune system is in our gut. So keeping our gut healthy will prevent us from getting many diseases down the line. And we can improve our gut health by eating a balanced diet rich in fruits and vegetables, and which will provide the fiber that builds good bacteria and gut health. Other foods that can build a healthy digestive system include fermented foods like kefir, which is basically like a fermented milk drink that's similar to yogurt and rich in probiotics. Other fermented foods are such as kimchi, sauerkraut are also good for the gut health. Managing stress levels. So experts in gut health often talk about the brain-gut connection and refer to the gut as the second brain. Research suggests that anxiety and depression are affected by the gut and vice versa. So anyone with IBS knows that when they're stressed or upset or anxious, it triggers their symptoms of abdominal pain and bowel changes like diarrhea. So managing stress is definitely a very important point. Exercising, because physical activity will keep the colon moving and will keep the bowels moving. Also, not eating too much, meaning eating smaller, more frequent meals to avoid overwhelming the GI tract. Drinking plenty of water, limiting alcohol and caffeine because those can be toxic to our system. And of course, with anything else that we lack and we need, get more sleep.
This has been wonderful. I actually have one final question for you. And that is, my patients who are older in their 70s will ask me, when do I stop screening for colon cancer? So yes. Is there an age cutoff?
So there's not per se, but it's only a recommendation, meaning at ages 76 to 85, you have to individualize. So at 76, I always look at my patient and look at their physical health and their history and outweigh the risk benefits of screening. So we have to individualize screening after the age of 76. So 76 is the age where we say, do you need to be screened or not? And I can tell you there are a lot of 76-year-old out there or 78 or 79-year-old who are very, very healthy. And people are living much, much longer now. So you do have to look at their physical status and individualize.
Great. Well, this has been so helpful, and I appreciate you being willing to talk to us today. I know you're extremely busy, as is Dr. Firoozi. Appreciate both of your participation, but if I could ask you to stay on for the rest of the time, because we may have some questions for you. So thank you again.
Thank you.
Thank you.
So now we're going to talk about sex. What is sex is my first question that I'm going to attempt to answer. So, sex and sexuality is an integral part of the personality of everyone, man, woman, and child. It's a basic need and an aspect of being human that can't be separated from other aspects of life. However, it hasn't really been recognized by most healthcare providers as a real medical entity. And there are reasons why we don't bring up our sexual concerns with our doctors. We're concerned that there may be no medical treatment for the problem. We're concerned about our doctors may dismiss us or laugh at us, God forbid. And if that's the case, it's important to come to your doctor with a list of questions and make sure you're being taken seriously. I've heard from patients that I don't want to upset my doctor. Well, you know, who is the patient here? It's the doctor-patient relationship. It's a relationship. You have to be comfortable. Try your best. Try to be comfortable. Bring your questions. If you're not comfortable, it may be time to find another doctor. And that is another reason we may not bring up our concerns. Healthy sexual functioning improves self-image, nurtures our relationships, and increases our motivation to take better care of ourselves in other areas, such as with diabetes or hypertension. Menopause and aging may compromise our healthy sexual functioning. Because of this, it's important to bring up our concerns with our doctors and to take these seriously. So there's a big difference between men and women. I think we know that sexually, and as we age, things do change. We want to be appreciated. The brain for women is actually the most important sexual organ, and the connection between the brain and the genitals is totally crucial. We desire intimacy to achieve orgasm for many of us. As opposed to men, a release of orgasm for them is a stress reliever and also may involve intimacy, of course, but it's mainly used to relieve tension and reduce stress. Women, basically, there's an intimacy-based model of female sexual response where we can jump in at any part of the cycle, including emotional intimacy. We may see something that turns us on, sexual stimuli, spontaneous sexual drive, arousal, biological and psychological factors, but mainly we need our minds and our bodies to interact. Very important. There are some myths about sex that it always involves a younger couple, always involves a couple. We can be sexually active by ourselves and have a wonderful relationship with ourselves. A myth is that sex involves male and female, and that it only happens in the bedroom. Well, we know from when we were younger that there are lots of other places besides the bedroom that sex can happen. So basically, desire is very complex. It involves your body image, your life experiences, your health, hormonal changes, and so forth. However, sexual desire may be negatively impacted by depression, by antidepressive medication. Don't change your medications, talk to your doctor, but this may be a factor. Stress, of course, we know that stress impacts sexual functioning. The quality of your relationship and declining and changing hormonal levels as well. So it's very important to make sure that your relationship is if it's with another person, regardless of gender, that it is a good, healthy relationship and that there is no intimate partner violence or domestic violence. In that case, it's important to talk to someone, get support, and get help. The second question is, why does my vagina seem different in menopause? What about orgasm? It takes longer and so forth. Why is it so different? Well, it's similar to the first answer, that there's a balance between our brains and our genitals, that there's a balance between the cardiovascular system, our lungs, our musculoskeletal system. It may be more difficult to get into different positions. When we were younger, maybe easier. It may be very difficult now because of arthritis and so forth. And there's an impact on the endocrine system and hormones on our sexual functioning. So if you have a thyroid disease that is not controlled well, you may have difficulty achieving orgasm. If you have diabetes that's not controlled well, it may be difficult to achieve orgasm. We are complex creatures. We like variety. Many of us crave romance. Sensory stimulation is important, communication with ourselves or our partners, and you have to really be in the mood. And technique is very important, and a lot of foreplay, especially in menopause, is extremely important. And of course, we don't want to forget about passion. The third area I want to address is sex as we age. What's important to know? As we go through menopause and as we age, we do change in terms of orgasmic potential, vaginal dryness. Our vaginas may get less elastic. We may have pain or burning with sexual activity. We may have an increase or decrease in clitoral sensitivity and orgasmic response and a change in libido. Well, it's very important to make sure we walk around with our vaginas every day, and yet we just use lubrication sometimes for sex. Well, lubricating your vagina with sex only is like with a menopausal vagina, is like trying to land a plane on an icy runway. You can't do it. So it's very important to moisturize your vagina like you moisturize your face. Most of us put on some cream or something most nights. Put a moisturizer in the vagina. There are many over-the-counter ones that are non-hormonal. To do that a couple of times a week, and lots of lubrication and lots of foreplay for sex. You may have a hormonal imbalance. In menopause, estrogen levels go down, and there are treatments for those. You can take an estrogen hormonal replacement therapy as long as it's with your physician, and there's no problem with any vaginal bleeding, and your mammogram is normal. The most useful vaginal estrogens I have found are not even oral or the patch, although those are available. They're vaginal estrogens, and they come in the form of the vaginal pill that you put in the vagina twice a week, or a vaginal cream or a vaginal ring. And the ring is used for 3 months, and then you take it out, throw it away, put in a new one. And those may help the vagina tremendously, in addition to moisture and lubrication. Moisture during the week, lubrication for intercourse of any or sexual activity of any type. And again, thyroid function is important. That's very, very important for women to check that. So in terms of safe sex, I want to finish the last few parts of my portion of the talk to mention that women still can get sexually transmitted infections even if you are older. And that goes for if you're a widow and you're dating a widower and you're sexually active, or you're a widow and you're dating a widow. You still can get a gonorrhea and chlamydia and syphilis and AIDS and hepatitis from your partner, whether or not your partner is the same gender or different gender. Okay. And it's very difficult to have this conversation with your partner, especially, they look nice. I hear this all the time from my women in menopause. Oh, he looks so clean. He's only been with one other person. Go together you go to the gynecologist. He goes to the internist. You both get tested with urine test for chlamydia and gonorrhea and blood test for example, AIDS and syphilis, for example. Very important to make sure you're both healthy. Now, if he or she does not want to go get tested, what does that say about their commitment to you or their feeling about you? So if somebody doesn't want to get tested and says, I'm fine, I don't need to, you have to think about the relationship. You don't necessarily have to end it, but you do have to think about it in a little bit of a different context. I want to talk about the fact that the highest rate of unintended pregnancy for women is in the 40s. So if you're missing a period and you think you're in menopause, it may not be menopause. It may actually be pregnancy. Very important. I had a patient come to me with hot flashes, and I said to her that I would help her with her hot flashes in 4 months when I delivered her baby. She was 48 years old. So if you're having heterosexual sex, and you're in your 40s or you haven't reached menopause, for some women, early 50s, average age of menopause in the United States is about 52. So if you're still menstruating at least some of the time, you may have the ability to get pregnant. So make sure you're using a contraceptive. Very, very important. We don't want to assume that everybody is heterosexual either. Sometimes in menopause, women decide that they would like to try to have a relationship with another woman, and same for men, as a matter of fact. So we don't assume that everybody is purely heterosexual. Actually, 12% of the population reports in menopause same-sex attraction or behavior, and a change in sexual preference may occur in menopause, actually. So just remember that a good sex life and a healthy partnership can boost your life force. So what goes around truly comes around. And passion is connected to the heart, soul, brain, and genitals. Dr. Jennifer McKelvey, welcome. I have a couple of questions for you. My first question is, we know that the physician-patient relationship at its best is based on trust and that it's important to be transparent. But what if my feelings get in the way of being honest with my doctor?
That's a really great question. I think it is important to separate in these instances, separate the emotion from your behavior. So if you can think of a time when maybe you got really angry at someone and yet you still had to be nice to them or civil, at least, that's an example of separating the emotion from your behavior. So realizing that you can have an emotion that we view as negative, like anxiety or fear, and still speak despite that fear. And then, in thinking about this, I also considered the fact that we get hung up on words. So words can take on a lot of discomforting connotations. So if you think of the word like vagina or penis, people might not be comfortable saying those words. And so my suggestion at that point is to practice. It might sound a little strange, but practicing saying the words can help sort of separate any of the connotations you have with it with the actual word. So you can sit in a room by yourself and just keep saying the words that you're most uncomfortable with out loud, over and over and over, as loud as you can, until they sort of stop having any real meaning to them. and then just practicing that leading up to your appointment with your doctor. And an initial way you might get used to doing this is using the word milk. So we're all fairly comfortable with the word milk, but if you sit and for 30 seconds, as loud as you can without screaming, say milk, 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 milk over and over and over, it just starts being sounds, and has, with the words that you're uncomfortable with, will allow you to work with that discomfort and have it become less over time.
I have another question for you. Things have happened in my past that make it nearly impossible to go to the doctor, even though I know I need to go. What can I do about this?
That's a really, really tough situation to be in. So a lot of the time when we think of things that happened in our past that make going to the doctor uncomfortable, it goes along with some sort of trauma or traumatic experience, or just a phobia of things. So with past history of trauma, if a person is not already in treatment, I typically suggest getting some trauma-specific treatment so that you can address those issues, because it's fairly rare when a person has trauma in their history for it to only affect one area of their lives. It often affects other areas as well. So getting connected with good trauma-informed treatment is really important. And then with phobias, there are also excellent therapists out there who treat phobias, and addressing that phobia is also very important. It's hard when you have those overwhelming sort of memories or flashbacks or fears that subsume everything else to be able to even make an appointment with a doctor. But with appropriate treatment, it can help you in the future in, taking care of your physical health. And you can also seek physicians that are sensitive to these issues. So you don't necessarily have to go into the detail of the trauma that you experienced or in the past, but you can let them know that you have trauma related to the lower half of your body or the upper half of your body, or that type of thing. And there are practitioners and physicians who are very, very sensitive to these things and will do everything in their power to make the experience as comfortable as it can possibly be. And then there are also physicians who are also very sensitive to phobias. So seeking out those individuals, whether it's through word of mouth or talking to your therapist or talking to a psychiatrist, who can help get you connected to those providers that will, follow your guidance on the things that you can deal with and the things that maybe you can't at that moment. And then if you're comfortable with it, looping in your psychiatrist or your therapist to help you have that conversation with them. So everyone is very clear on how to make the best of what can be a very challenging experience.
I have one final question for you. What if a patient says, I get anxious when I go to the doctor and I forget what to say? How can I deal with that?
Well, I've had that come up quite a bit, not just for people I work with, but friends, family, myself. So even if you don't have anxiety, if you've ever had the experience of walking out of a doctor's office and going, darn, I should have asked them about this particular thing, right? So I would suggest in the day or so leading up to your appointment, making a list of questions that you would like to ask. And, maybe if you tend to do your best thinking at night or as you're trying to fall asleep, have a notepad next to your bed so you can jot things down so it's not keeping you up trying to remember them. So that's a good way to do it. You can put it on your phone, type it into your phone, or take a picture of your written questions so that you don't forget. And then if you're just generally anxious about going to any doctor, which many people are, see if a friend or family can go with you. And if you are comfortable with it, discussing with them the questions that you would like to ask the doctor and having them help either prompt you in your visit with the doctor or in some cases ask the question for you so that you can get the information that you need. And then with the responses, you can either that you get from your doctor, you can either write them down or ask your friend or family member to jot them down, because, you know, if you're expecting good news, bad news, absorbing all of that information can be really challenging. So it's really important to have sort of just those little tools that you can use to help yourself both ask the questions and then retain the information that's provided to you. So I think that is sort of the best way to go about it. And also to call your doctor afterward. And if you forgot something or misunderstood something, some directions that you were given later, just call. And a lot of doctors are willing to answer. Or if there's a portal for the electronic medical record, often you can email your doctor that way. And so those are just some little things that you can do to help you get through a doctor's appointment.
Thank you, Dr. McKelvey. That was very enlightening and much appreciated.
And thank you. Thank you for having me.
So thank you, Dr. Firoozi, Dr. DeVito, Dr. McKelvey, for this very informative session. You have provided tremendous insight into these very vital issues. And thank you, our audience members, for your attendance and attention and participation. We know your time is valuable, and we appreciate your spending your time with us today. Please remember to keep in mind the colon cancer screening guidelines and what you can do to promote your gut health. The importance of transparency in the patient-doctor relationship, understanding pelvic floor problems and what can be done for them, and finally, ensuring your sexual health for a lifetime. Be sure to tune in to the other conference sessions. We hope that the rest of your day will be wonderful. Thank you so much.
Hello, and thank you for attending this workshop. I am Dr. Nina Vinkoff. I am a radiologist specializing in breast imaging, and at Northwell Health, I'm a vice chair in the Department of Radiology and the chief of the Division of Breast Imaging. Today, I am honored to be moderating a conversation between two of my colleagues who are experts in breast cancer care. I have Dr. Swetha Dasari and Dr. Cindy Sen. I will allow them to introduce themselves in a moment, but I wanted to tell you a little bit about our workshop, which is entitled, I Found a Lump, Now What? We are going to be talking about some of the changes that women may experience in their breasts, what's normal and what's not, and when you should talk to your doctor and what kinds of testing your doctor might do. Before we begin, I'm going to allow my panelists to introduce themselves, and I'll start with Dr. Sen.
Hi, everyone. My name is Dr. Cindy Sen, and I am a surgeon at Northwell. I am from New York originally, and I did my undergraduate studies at Harvard. I went to medical school at NYU. I went on for my surgical training at Northwell, followed by my specialization in breast cancer care at NYU, and now I'm back here at Northwell. I operate at Forest Hills Hospital, Long Island Jewish, and Glen Cove Hospital.
Excellent. And Dr. Dasari?
Hi, everyone. My name is Swetha Desari, and I'm the Director of Women's Imaging at Phelps Hospital in Sleepy Hollow, New York, a part of Northwell Health. I'm truly passionate about breast imaging. And to give you a little bit of information about my background, after attending college at Johns Hopkins, I went to medical school at Albert Einstein College of Medicine in New York, and then did a residency in diagnostic radiology at Westchester Medical Center. After 1 year in Pittsburgh doing a fellowship in women's imaging, I returned to New York and began working at Northwell, and I've been here ever since.
Excellent. I'm so happy to have both of you here today to discuss these important topics. I'm going to be starting with Dr. Sen. Dr. Sen, many women have questions about what's normal and what's not when it comes to their breasts. They aren't sure what they're feeling and whether it's important. What kinds of changes should women be looking for in their breasts, and when should they talk to their doctor?
Right. This is definitely something that I ask all my patients, regardless of why they come to see me. The changes that I ask about are any lumps, any nipple discharge, any changes to the nipple or the skin. Lumps are kind of obvious, though many women have lumpy breasts and they don't necessarily know what a normal lump is versus a lump that might be more concerning for cancer. The lumps that I worry about are those that are hard, feel kind of out of place, or those that grow in size. For nipple discharge, this can be a normal finding, especially in younger women who may have recently had a baby or completed breastfeeding. Discharge is milky, especially if it's coming out from both sides and only with squeezing. That's not usually a cause for concern. But when discharge that comes out by itself, which we call spontaneous, if it's bloody, if it's coming up from just one side, those are red flags that require further workup. Other changes to the nipple or skin, that's important to watch out for. Say a new nipple retraction or inversion are things to bring up. Some women may have naturally inverted nipples, and that's not a cause for concern. But if they previously pointed outward and over the past weeks or months, one of them has started to pull back, to retract, invert, that needs to be investigated. Skin changes to note involve like a scaly rash that might develop on the nipple. Also any kind of swelling, redness, dimpling of the skin of the breast. That can be something as simple as a breast infection, but can signify something more serious like an underlying cancer. In these cases, I would advise a patient to get breast imaging done, and that might possibly lead to a biopsy.
As we know, many women actually experience pain in their breasts. It's very common. Dr. Desari, when is breast pain normal, and when is pain something that should be evaluated by a doctor?
The good news is that although breast pain is uncomfortable and can be very bothersome, it's usually not associated with a breast cancer. So quote unquote normal breast pain usually involves both breasts. It's cyclical, meaning it comes and goes in a pattern that's predictable and related to your menstrual cycle. So this type of pain tends to get worse in the days leading up to your period and then lessens after you have your period. And pain that we would consider to be more concerning would be the type that's only in one breast or in one specific location in one breast. And it would be persistent, meaning it's not that cyclical type and it doesn't change with your menstrual cycle. It's there every day. Accordingly, pain in a woman who is post-menopausal would also be a little bit more concerning as well.
Okay, thank you. There's been some difference of opinion in recent years about whether women should do regular self-breast exams or whether instead of doing a self-breast exam, women should just be aware of what's normal for them and for their own body and be alert to changes. Dr. Sen, do you advise that women do regular self-breast exams?
Yes, absolutely. I think that women are a little intimidated by the term breast self-exam. They think that they need a medical degree to be able to do one properly. But I stress to them that it's all about being body aware. The important thing is really to get to know your landscape, to know the texture of your own breasts. And that way you can really say that if you notice a new lump, there's a change in the nipple, you can be confident in saying, this is not normal for me, this is new, and this is concerning. And that can lead to an earlier mammogram than your normally scheduled mammogram, and that can lead to an earlier diagnosis and lead to better outcomes.
Okay, excellent advice. Thank you so much. Again, Dr. Sen, can you walk us through what happens if a woman comes to your office with a new breast symptom? It could be something that she found herself or something that her doctor or gynecologist found on a clinical breast exam. how do you determine if further testing is needed, and what kind of testing might you order?
Right. So usually before coming to see me, having heard about, say, a new lump or a new finding, I would prefer that a patient get certain studies done first. For women over 30, a diagnostic mammogram and an ultrasound are good ways to investigate if something is underlying that symptom. For women under 30, usually just an ultrasound is ordered. Mammograms may not be as helpful for younger women. But in either case, if something is seen, then a biopsy may be the next recommendation. These are performed by you guys, the breast radiologists. When the results are available, then the patient is welcome to come see me in the office, and then we can talk about what the next steps might be, whether further surveillance or maybe surgery. Sometimes, someone may have a symptom, but nothing is seen on mammogram or ultrasound. And at that point, I have the patient come in and we can talk, and then we can decide if maybe further imaging like an MRI might be appropriate.
So you prefer that a patient have their imaging done first and then come and see you afterwards, so that you're able to discuss their imaging exam with them when they come and have their consultation in the office?
Correct, exactly. That way, if they need a biopsy, then we can talk about what that shows and we can make a plan with that information.
Excellent. So Dr. Desari, we know that there are two different kinds of mammograms. There's the ones that we call screening, and there's the ones that we call diagnostic. And this can really be a topic that's very confusing for women. What is the difference between a screening mammogram and a diagnostic mammogram? And which mammogram is it that a woman who has a new lump or a new symptom or a change in her breast should be having?
So you're absolutely right. This can be very confusing for women and referring physicians as well. So I'll try to simplify it a little bit. So a screening mammogram is just the terminology that we use to describe a mammogram in a woman who has no breast symptoms or no breast concerns at all. So no lump, no nipple discharge, none of those things. So she would be simply having her annual exam that she gets once a year. The woman that has the screening mammogram done usually just has the test performed and then goes home right after, and then she gets her results either by a telephone call or by a letter in the mail. Now, a diagnostic mammogram is the terminology we use for a mammogram that's done in a woman that has some kind of breast concern. So it could be any of these breast changes that we've talked about today: a lump, pain, focal pain, or nipple discharge. And after she has this diagnostic mammogram done, a radiologist will look at her images immediately and then decide whether she needs any additional mammographic views or if she needs a breast ultrasound. And then these studies would be performed right away, and the ultrasound technologist would scan the patient if necessary. And often the radiologists may come in as well and take a look themselves with the ultrasound. And then before the patient leaves the department, the radiologist will give the patient the results of all the tests that they've had done and give their recommendation about what kind of follow-up would be needed. And if they do see something concerning, then they would recommend a biopsy at that time. If they see something benign, like a cyst, then the patient would just be advised to come back in a year for their annual screening mammogram. Once in a while, we'll recommend a shorter term follow-up for example, in 6 months usually, and that's just to keep a closer eye on a finding that we think is most likely and probably benign.
Thank you so much. I think the reason why it's confusing is because we have these two different names, and I know I personally have had women say to me, are we using a different machine? Is there a different technique that we use? And, the basic answer for that, as you and I both know, is it's the same mammogram machine that we use, but it's the way that we take the pictures. So for a screening mammogram, we're just going to take the 4 standard pictures. Whereas for a diagnostic mammogram, depending on what you tell us the problem might be, we might choose to take different kinds of pictures. And that's the difference. And the other difference, as you stated, is that when you're having a screening mammogram, you're probably going to be getting the results after the fact. Whereas with a diagnostic mammogram, absolutely 100% of the time, you'll be getting the results before you leave the office and an answer to the question that brought you there. So Dr. Desari, this leads me to the next topic, which is what's the difference between a mammogram and an ultrasound? And should a woman who have new symptoms have a mammogram, or should they have an ultrasound, or should they have both?
So a mammogram is a set of pictures that's taken of the breast, and it uses very low dose, very low energy x-rays. So we place the patient's breasts in compression as we take the pictures. And this helps us to reduce motion and get clearer images so we can find subtle findings. The radiologist can then look at these images and they use a special monitor searching for any signs of cancer. And the mammogram can actually be done in 2D or 3D. And at Northwell, we use 3D as our standard of care. So an ultrasound is an exam that most women are probably already familiar with if they've had children, as you tend to have a lot of these when you're pregnant. And a probe is used to scan over the breasts, and gentle pressure is applied as they do it. And the woman is generally lying on their back or on their side when this is happening. And the ultrasound machine works through the use of sound waves. So there's absolutely no radiation involved, like with a mammogram. And we take images of the breast. Usually it's performed by an ultrasound technologist and then evaluated by the radiologist. And like I mentioned, sometimes the radiologist may come in and scan his or herself to get a better idea of what's going on in real time. So women with new symptoms may need to have one or both of these tests, a mammogram and or an ultrasound. Generally, like we mentioned, if you're older than 30 years, we would start with a mammogram first and then do an ultrasound as well if we think it's necessary. If you're under 30 years old and have new symptoms, we usually start with an ultrasound just because there is that lack of radiation exposure. And with younger women, we want to be a little bit more cautious about radiation exposure because their breasts and body in general is a bit more sensitive to the effects of radiation. And then if we truly think a mammogram is needed in these younger patients, we can always get one after the ultrasound's done.
Thank you very much. I think it's difficult for a lot of women to understand what the difference might be, and a lot of it, I think, really just comes down to X-ray is what we use for mammography, sound waves are what we use for ultrasound, and then magnetic waves are what we use for breast MRI, which we're not going to talk about a lot here. And I have women ask me all the time, why do I need to do both? Or, why can't we just have one kind of test? And I think really the answer is because each one of those kinds of energies give us a different kind of way of looking at the breast. And we haven't found the one test that does it all perfectly. They each see things a little bit differently. So Dr. Dasari, I have a question for you. You talked a little bit about radiation exposure, and I know there's a lot of confusion about this topic. What if a woman notices a change in her breast during pregnancy? Can she still have a mammogram?
The answer is yes. Yes, she can have a mammogram, even if she's pregnant. And if she notices a change in her breast, she really should have the mammogram. And the reason is, if she does have a breast cancer, it could be pretty fast growing, especially given the hormonal changes that happen during pregnancy, the higher estrogen and progesterone levels specifically. So if a woman is pregnant and she has some kind of new breast symptom, we usually start with an ultrasound just to see if that will answer the question about what's going on. If that doesn't, however, then a mammogram can be very helpful to answer that question. And the amount of radiation involved is very, very low. And because the energy of the X-rays themselves are very low, they don't travel very far away from the breast to other parts of her body, including her belly. But in any case, to be extra careful, we can place a lead shield over the pregnant woman's belly, and this provides some additional protection for the fetus as well.
Thank you. I think it's really important for women who are pregnant or breastfeeding, we'll talk about breastfeeding a little bit in a minute, to remember that not only can you get breast cancer when you're pregnant or breastfeeding, but certain kinds of cancers are going to grow fast during times that you have that kind of hormonal stimulation, and to not put off getting these things evaluated because of fear. Because as you rightfully said, the dose from a mammogram is very, very low, not dangerous to the fetus, and really important that you get new symptoms evaluated when you're pregnant, because they could be something important. Dr. Sen, let's talk a little bit about breastfeeding. Lots of women experience changes in their breast during breastfeeding. It can be very, very confusing to know what's normal and what's not, especially if it's your first time breastfeeding. So what kinds of things should women be alert to while they're breastfeeding?
Right. Breastfeeding is fantastic. It's a really natural way to bond with your baby, but it's not easy. And I know that from experience, particularly in the very early stages, right after birth, the breasts become engorged, very uncomfortable. It takes a while for this supply to regulate. And if the breast doesn't empty fully, the milk ducts can get clogged, which leads to inflammation. And that inflammation of the breast is called mastitis. The breast can feel swollen, it's red. The milk ducts again, they're not draining, and it can be very painful. So when untreated, it can progress to the woman having fevers, feeling sick like having the flu, and then ultimately form an abscess that will require drainage. The best thing to do is to treat mastitis early with antibiotics and to fix the underlying problem, which is usually that clogged milk duct.
Excellent. Thank you. So again, it comes down to getting attention when you notice a change and not to be embarrassed, I think, especially if it's your first time breastfeeding and not knowing whether what you're feeling is normal or not. Better to show it to your doctor and find out whether it is or not than to take a problem that might be small and have it turn out to be something bigger. And of course, you mentioned mastitis, but as we know, breast cancer can also occur during breastfeeding. So all the more reason why, if you're not sure what's going on, if you're not sure what's normal for you, to show it to your doctor. So Dr. Desari, what are some of the things that you might find on a mammogram or an ultrasound if a woman's having a lump? And what kinds of things might you find that are normal? And how do you know when to recommend a follow-up exam? And how do you know when to recommend a biopsy?
So, if a woman feels a lump, it can be due to a number of reasons. And the good news is that it's usually due to something benign like a cyst, and cysts are very, very common in women. It could also be due to a lymph node or a benign solid mass, like something called a fibroadenoma, which is very, very common as well. So if we see a concerning or an indeterminate finding on a mammogram or on a breast ultrasound or both studies, we would recommend a biopsy. And concerning findings have a particular appearance, and that's how we decide which ones to recommend a biopsy for. So they may be really dense in appearance, very irregular in shape, or even cause some pulling in of the surrounding tissue around it. And occasionally, the radiologist will make a finding on the mammogram or breast ultrasound and describe it as quote unquote probably benign. And that just means that there is a very, very small chance of this type of finding being an actual cancer, less than 2% chance, in fact. And this is the situation where we would recommend that the patient come back for a shorter term follow-up, just to make sure it doesn't change in any sort of concerning way. And the follow-up is usually done in 6 months, but can vary a little bit. So for example, a finding on ultrasound that we might recommend a 6-month follow-up for may be a mass that's very oval and round and not irregular in shape at all, and one that we would feel comfortable saying this is most likely going to be a benign finding.
So just to paraphrase a little bit what you just said, it seems like there's 3 different categories of things that women should be aware could happen when they go and get their finding evaluated with imaging. One is that we see something that we know is normal, and we can tell you right there and then that's normal. That's a cyst, it's normal, nothing else needs to be done. There are some things that we say, we're not sure, that might be a cancer, we're gonna need to do a biopsy in order to know. And then there's that third category that you just mentioned, that we feel very, very confident that this is not going to be a cancer, but we want to keep an eye on the area just to make sure there's a very small chance that it could turn out to be something important. And so we're going to have you come back again in 6 months just to make sure that there hasn't been any change. And then if there has, maybe at that point we would decide to do a biopsy. So Dr. Desari, both radiologists and breast surgeons, as we know, can do needle biopsies. Here in Northwell, most of the needle biopsies are done by radiologists. Can you just briefly walk us through what it's like to have a breast biopsy? If something is found on a mammogram or on an ultrasound, how is the biopsy performed?
Sure. So there are 3 types of breast biopsies that we perform as radiologists. And the difference really is the type of imaging that we use to guide the biopsy itself. So if we see a finding on breast ultrasound and we decide to biopsy it, we perform the biopsy under ultrasound guidance. And this is really the easiest and quickest type of biopsy that we do. The patients prefer it compared to the other types because their breast does not have to be in compression. The patient actually is lying flat on their back during the procedure, and we just clean the skin. We give a little bit of local numbing medication, usually with lidocaine, through a little needle, and then we insert a small needle into the breast and take a few samples of the area of interest. We then place a tiny little biopsy marker in the location where we do the biopsy. And that's just to mark the area in case it can't be seen well after the biopsy is done. And we are visualizing the area that we're working in with ultrasound guidance throughout the entirety of the procedure. And that helps us to make sure that we're taking really good samples of the target. Now, if a finding can't be seen with ultrasound, but only on a mammogram image or only with MRI imaging, then we perform the biopsy using that type of guidance. So either mammographic or MRI guidance. And a biopsy that's done with mammographic guidance is called a stereotactic biopsy. And in that type of biopsy, the breast does have to be placed in compression. We take a few pictures to find the area that we're looking for and make sure that we sample it well during the procedure. And just like with any type of biopsy, we then just clean the skin, we give local numbing medication, and we put a little needle in and take several samples. And then at the end, a biopsy marker is placed. So an MR-guided biopsy is done when we only see the finding on MRI and not on the mammogram and not on the ultrasound either. And in this type of biopsy, the patient would have to lie face down on the MRI table with their breast hanging down through a special biopsy coil to support the breast. And we do have to use some breast compression for this type of biopsy. So in this case, the woman would be placed into the MRI scanner to obtain the images and find the area and make sure we sample it well. And they are placed in the scanner intermittently as we do the biopsy, not for the entirety of it. And then again, we just clean the skin, we give local numbing medication, put a needle in, and take a few samples of the target. And then afterwards, as always, a biopsy marker is placed in that area.
Thank you. I think, one of the things that I think is scary if you've never had a biopsy is that sounded like a lot of description. But I think Dr. Desari and I could tell you that each one of those kinds of biopsies actually only takes us a few minutes to do. And a lot of the time that you're in the office is just the preparation for the biopsy and then sort of cleaning up and giving you the instructions afterwards. But the time that you're actually in compression for your mammogram or lying on your back having the biopsy and ultrasound or lying on your belly having the biopsy and MRI, those periods of time are short. And we give you lots of local anesthetic, so you're all numb during it. And it's really not an uncomfortable or unpleasant experience for the majority of women. And most people actually leave our office. A lot of people will go back to work as long as you're not going to be doing strenuous activity or heavy lifting. We don't need to give you anything that would impact you from driving or any other kind of activity. It's usually just a little ice pack and maybe some Tylenol if you're having more discomfort than what we can take care of with the ice pack. So not all biopsies are going to find cancer. And I think that that's a really important thing for women to realize. And in fact, it's actually the minority. Only about a quarter of all the breast biopsies that we do find breast cancer, which means that 3/4 or more of all the things that you might be recommended to have a biopsy for are not going to turn out to be cancer. And I think that's really important to remind yourself if you're somebody that gets recommended to have a biopsy. Still, most likely, we're going to find something that's not cancer. So Dr. Sen, what are some of the things that we find on a breast biopsy that are not cancer? And which things need to be treated with surgery? Which things need to be removed?
Right, definitely. I do, again, stress to my patients that the majority of biopsy recommendations lead to benign findings, but there's certain benign findings that still are considered high-risk lesions or high-risk findings that require surgery to make sure that there's not an early-stage cancer that might be nearby. These findings include intraductal papillomas, radial scars, atypical ductal or lobular hyperplasia, and something called LCIS, that's lobular carcinoma in situ. That term contains the word carcinoma, and that freaks out a lot of patients. It's scary to hear, and some people might recognize its ductal counterpart, DCIS, ductal carcinoma in situ, that is actually considered early stage cancer. But LCIS, the lobular carcinoma in situ, is not. It's considered just a marker for cancer. So if we see that on a biopsy, again, it's benign, but that along with the other diagnoses, the intraductal papillomas, the radial scars, et cetera, these patients come to see me and we talk about doing an excisional biopsy of that area in question. And again, even after excising these areas, most of the time there's no upgrade to cancer, and that's great. But even if the surgery doesn't find any cancer now, they are still considered to be at high risk for developing cancer in the future. And so for these patients, I tell them a few things. One thing is they should undergo further screening. So in addition to the yearly mammogram, I think some of them might qualify for a yearly screening MRI. They can also meet with a medical oncologist where they can be offered medications that can lower their risk for breast cancer in the future. And for women with these high risk findings and maybe some other high risk factors as well, like significant family history, then we can talk about prophylactic mastectomies. But again, I reserve that for the very highest risk patients.
So there's really, again, there are 3 different categories of things that can happen after you have your biopsy. You could get a call to say it's completely normal, nothing there to worry about or think about, something like a fibroadenoma that has no chance of becoming cancer. It could be the situation, the small percentage of cases where it does turn out to be a cancer, or it could be one of these in between or high risk things that you just talked about, where you might need to have surgery so that it doesn't become a bigger problem down the road. You might even consider taking certain kinds of medications that are going to prevent you from or help reduce your risk rather for developing cancer down the road. But there's a lot of terms with a lot of big words that people may be saying to you after you have your biopsy that are not cancer, but that still might require a little bit more work before we're done. So those are things to keep in mind. That the call is not going to be yes or no. Sometimes it's a longer conversation after you have the biopsy than just everything is fine or you have cancer. Sometimes it's one of these in-between conversations. So that's something to be prepared for when you're having a biopsy, that kind of conversation could happen. So Dr. Sen, if a woman has a breast biopsy and it does turn out to be cancer, what happens next? What kind of testing is done next? And how do you decide what's going to be the best course of treatment?
Right. So unfortunately, while a lot of biopsies are benign, that minority does find cancer, and that is every woman's worst nightmare. The good thing is that breast cancer, kind of good, is that it is common. So this journey that follows is one that is very well established. A lot of women have gone through it. And so the guidelines, there's a lot of support out there. And so there's very common things that happen after. So first, after the diagnosis on the biopsy, additional tests. First, they do testing for 3 receptors. There's the estrogen receptor, progesterone receptor, and something called the HER2 receptor, which is just a special protein. Once we know where the cancer stands on each of these, then that further dictates what kind of treatments are available. At this point, I meet with the patient. We go through the diagnosis. We go through what these, again, the estrogen, progesterone, and HER2 receptors are. And then we talk about surgery. Mainly, the 2 options are either removing the whole breast, which we call a mastectomy, or taking just the part of the breast with the cancer in it, which we call a lumpectomy. This is breast conservation. Other parts of breast cancer care include chemotherapy, radiation, and or hormonal therapy. And that depends on exactly what kind of cancer you have. Most cases are straightforward, but for the ones that are less so, at least at Northwell, we have conferences twice a week where the different disciplines come together: the surgeons, the medical oncologists, the radiation oncologists, the breast imagers, and the pathologists. And we discuss the cases that are not that straightforward. As a team, we come up with a treatment plan.
Thank you. I think it's really important for women to know that there isn't just breast cancer. There's not one thing that's breast cancer. Breast cancer is really a huge umbrella of a lot of different things. And so what's going to happen to you next if someone tells you that you have breast cancer really depends on so many specific factors that are specific to you and to what's going on in your breast. And so your breast cancer is not the same as your friend's breast cancer or your mother's breast cancer. And I think it's also really important that women not spend too much time Googling about breast cancer, because what you read might not actually apply to your situation. This is why we have groups of experts that decide how to treat each woman, is because each situation is different. And so while it's nice to get support from your friends, and you certainly, if you turn out to have breast cancer, you certainly will hear of lots of people that you can talk to, just keep in mind that their situation might not be the same as yours. I really want to thank both of you for this discussion today. It's been a great discussion, and you've provided a lot of information and hopefully taken some of the mystery out of what's important and what's not, what kinds of testing we do, what a biopsy experience is like, what kinds of results you might get from your biopsy, and what kinds of things might happen next. And I really believe that knowledge is power, and that for women who are watching this, knowing what to expect will hopefully be really comforting should you find yourself in any of these situations. I wanted to give each of my panelists an opportunity to give me some closing thoughts. So Dr. Dasari, if there's one thing that you hope that our viewers take away from this session today, what would it be?
So first, I want to thank everyone involved today for helping to educate women about their bodies and specifically about breast health. Like you said, there's a lot of misinformation out there on the internet and confusing information. So forums like this are a really great way to weed through all of that and get some real answers. And what I would like viewers to take away from this is, if you notice something different about your breasts, just say something. Say something to your primary care doctor, your OBGYN, and definitely say something to your radiologist when you come in for your imaging appointment. This is very, very important. And I would like women to also keep in mind that as breast radiologists, we understand that the whole process of breast imaging, whether it's screening or diagnostic imaging, and waiting for the results of these tests and biopsies can be very, very stressful for you. And we've really tried to do our best to minimize the stress as much as we can.
That's absolutely true. And I think I really wanted to emphasize one point that you made in there, which is about the importance of communication. When you come in to have your exam, please tell us what's going on. Sometimes we have patients who don't share the whole story of what they've been experiencing, and we can only do the right test when we really understand what's going on. So please don't be afraid to tell us, or don't think that we will figure it out based on the images that we take. Sometimes we take special pictures based on what you told us. And if you don't tell us, we're not going to take those pictures. So thank you so much for making that really important point. And Dr. Sen, any closing thoughts?
Yeah, I echo everything that Dr. Dasari mentioned. I think those are all great points. I hope that today's talk will encourage women not only to get their mammograms done, but also to feel empowered to examine themselves and be more body aware, to really get to know your baseline. And then you can recognize these changes and findings that are worrisome. And we cannot prevent a woman from getting breast cancer, but we can certainly find it earlier. And then at that point, people have better options and the outcomes are overall better when we treat earlier stage cancers.
I love what you said about empowering. I think there's a lot of fear when it comes to breast cancer. And I think it's really great if we can reframe everything that we talked about today as a way for you to take some control over your own health. And I think by doing that, you increase the chances that you're going to do well and go on to live a long, healthy life afterwards. So thank you so much to both of my panelists. This was a great conversation. I loved having the opportunity to talk with both of you. And thank you so much to the viewers for your attention. Thank you, Northwell Health and the Katz Institute for Women's Health for inviting us to present this workshop. And thank you to the 92nd Street Y for partnering with the Katz Institute in this Breast Health Summit. Together, we are raising health for women. Thank you.
Wow, what an incredible way to wrap up an amazing week. Thank you so much to the 92nd Street Y and to Nancy and Larry Roth for making this week possible. And thank you to all our experts for helping to educate us all and sharing what we need to know to live our healthiest lives. We'll be hosting additional virtual educational sessions later in the year. Please keep an eye out for your invitation to these events. The Katz Institute for Women's Health operates on a fundamental principle. Healthier women mean healthier families and ultimately healthier communities. We want to provide you with information and tools you need to make educated choices at every stage in your life, and we hope this week accomplished that goal. At the Katz Institute for Women's Health, we know that women's health encompasses the whole body, and we believe women's healthcare should too. Thank you for joining us.